Good morning. I'd like to welcome everyone to the subcommittee this morning, but especially Rear Admiral Michael D. Yaki. I knew I was close. The Principal Deputy Director of the Indian Health Service, which we will be referring to as to IHS for the rest of the day. The Rear Admiral testified before us in the subcommittee last year, and we're happy to have you back again today. And joining the Rear Admiral today is Ann Church, Acting Director of Finance and Accounting, and Rear Admiral retired Gary Hartz, Director of Environmental Health and Engineering. But before I get started into the details of this budget request, I must say that I'm extremely disappointed that the administration has still not nominated a director to lead IHS. I'm happy you're here, but we need a director. The Government Accountability Office, GAO, placed IHS on its high-risk program list, in part because of the service's lack of leadership. While I appreciate the Rear Admiral being here today, given his challenges facing IHS, a confirmed director is imperative, and I encourage the administration to submit a nominee to the Senate in the near future. Our hearing today will address the President's FY2020 budget request of $6 billion for the Indian Health Service. While the budget proposes $141 million increase, or a 2.4% over the FY2019 enacted level, it does not cover the cost of inflation and other fixed costs and falls short in addressing the health care needs of our Native American brothers and sisters. Native Americans have a shorter life expectancy. They suffer disproportionate from disease burdens associated with heart disease, cancer, diabetes, obesity, and other chronic illnesses. The statistics are sobering, yet the administration proposes a budget, in my opinion, that's nothing more than smoke and mirrors. For instance, the President proposes $20 million to begin a National Community Health Aid Program, or CHAP, a very worthy program, but at the same time reducing the funding for Community Health Representatives Program by $39 million. The Community Health Representatives provide important in-home services, and our tribal nations rely on them. Congress rejected the administration's proposal to eliminate the health representatives last year, and I'm disappointed to see the service turned it around and used it to offset its program CHAP. Another example is a proposed increase of $8 million in hospitals and health clinics to recruit and retain health professionals, accompanied by a $14 million in health professionals. So, I mean, there's an increase in hospitals and healthcare clinics to recruit, and then at the same time, this budget has a reduction in $14 million in health professionals. So how can the service really fill its critical health professional vacancies with a net decrease of $6 million to recruit and retrain and attain health professionals? I would be remiss if I did not point out that this budget proposal does not align with the service's FY 2019 through 2023 strategic plan, which was released in February, 2 weeks before this budget. The strategic plan was wisely recognized the need to recruit, develop, and retain healthcare providers and the importance of preventative care. I also want to note that given the estimated total facilities need for AHS is approximately $14.5 billion, the proposed $78 million cut to the facilities construction makes it a non-starter. This subcommittee recognizes the importance of programs proposed for the reduction or elimination, and no evidence has been presented that leads me to change my mind. That said, the proposals in the President's budget that address real concerns for Indian health services. From 2010 to 2017, there's been a 46% increase in the annual number of HIV diagnoses among Native Americans. As of 2016, Native Americans are 2.7 times more likely to die from hepatitis C than other non-Hispanic whites. The administration's focus on HIV and hepatitis C is timely. Though given the cost of the medication, I question whether the $25 million proposed in this request is enough to diagnose and treat both diseases. Since the service budget is already oversubscribed, the President's is unrealistic to think that HIV and hepatitis C initiatives can be funded without any additional money. For years, we have discussed the need for IHS to develop a comprehensive IT system without impacting services. The budget proposal of a separate line item is timely and it's appropriate and will ensure costs are transparent. But it's also important that the new system be interoperable with the Veterans Administration's new IT system. Speaking of the VA, the subcommittee will continue working with our MilCon colleagues to ensure that the VA's reimbursements for care provided by the service and address any lingering issues. And I heard a few this weekend. I am aware, Admiral, that you are only the messenger and that you are doing your best given the resources provided. The long-standing challenges facing the service require a confirmed director, and I thank you for your efforts to fill this void. And I want you to know I do appreciate your work and your dedication. But all that said, members of this committee, and quite frankly, everyone across the country, were outraged to learn that an IHS doctor had been convicted of child sexual abuse in Montana and is pending charges in South Dakota. We want to learn what you're doing to ensure that proper screening, credentialing, and reporting happens from now on. We need to know what the service is doing to ensure that this type of abuse, or frankly any abuse, never happens again. The subcommittee will begin crafting its 2020 appropriations bill that works hard to fulfill our treaty and trust obligations by meeting the health needs of Native Americans. We will also work with the authorizing committees, Budget, Natural Resources, Energy and Commerce, to move a bipartisan bill which I've introduced to provide advance appropriations for tribal programs. If it doesn't happen this year, we have laid the foundation. But we're not going to stop there either. In order to ensure that Native American health does not suffer if a sequestration occurs, because I'm hearing that in the halls of Congress, and I've heard it here at this conference table, we want to make sure that we have a language that will include an exemption for Indian Health Service from any sequestration in the future. The very lives of Native American peoples and their future generations depend upon a strong and robust Indian Health Service. Congress must not shortchange health care in Indian country. So once again, I look forward to working with you, sir, and to address the health care needs of Indian country and the challenges facing Indian Health Service. And now I'd like to yield to our ranking member, Mr. Joyce, for his opening remarks.
Thank you, Madam Chair, and I'd like to extend a warm welcome to our distinguished witnesses here today. Thank you for your continued leadership of the Indian Health Service during difficult times, and for being with us today to discuss the administration's FY20 budget for the Indian Health Service. Current law mandated the President submit an FY20 budget proposal to Congress that would cut non-defense discretionary spending by 9%. Despite those heavy constraints, this administration deserves some credit for proposing a 2% increase for Indian Health Service. It's not enough, but it's a step in the right direction, and it's a signal of the administration's understanding of the trust responsibility, and it's something we can work with. For instance, this proposal includes $69 million in increases for pay, inflation, and population growth that are needed just to keep pace with the current levels of service. This proposal also includes an additional $97 million for expanded staffing costs of recently completed and renovated facilities, fulfilling commitments made to tribes through joint venture construction agreements. Finally, this proposal includes a $147 million program increase to expand access to hospitals and health clinics, dental health, mental health, and alcohol and substance abuse treatment. In so doing, this proposed program increase is a clear recognition by the administration that merely maintaining current levels of service is not enough. We need to be increasing services. But whether we should be increasing some services in the IHS at the expense of others is another matter. And so I'm eager to hear the justifications for the proposed cuts in the budget. Congress declared in 2010 that it is policy of this nation, in fulfillment of its special trust responsibilities and legal obligations to the Indians, to ensure the highest possible health status for Indians and urban Indians to provide all resources necessary to effect that policy. The weight of that policy is probably felt most by this subcommittee. That is why serving as its new ranking member is not just an honor, but a heavy responsibility. Fortunately, we are not alone. Many of our colleagues in Congress understand that meeting our trust responsibilities and legal obligations to American Indians and Alaska Natives is a responsibility shared by all members of Congress. Madam Chair, thank you again for holding this important hearing today. I look forward to working with you and the rest of our colleagues in the coming days and weeks to do what we can to provide the resources in FY20 to meet this responsibility. I yield back.
Thank you, Mr. Joyce. And as you know, when it comes to Native American issues, we just don't work bipartisanly. We work nonpartisanly on this subcommittee. So thank you for your words. Just to kind of set the scene for you, Appropriations has meetings going on all over. And the reason why we have so many meetings kind of meeting at the same time is we're trying to catch up from the shutdown, and we're trying to get our subcommittee bills ready to go when we have our allocations through CAPS, and then we need to have everything on the floor by June. So a lot of activity. People are watching, and we have a lot of staff here, and people will be coming in and out, and it means no disrespect to you, sir. With that, your full testimony will be entered into the record. And if you would please give us your testimony at that time, we'd appreciate it.
Good morning, Chair McCollum, Ranking Member Joyce, and members of the subcommittee. I'm Rear Admiral Michael Yaki, Principal Deputy Director of the Indian Health Service, a member of the Zuni tribe from New Mexico and Arizona. I want to thank you for your support and for the opportunity to testify on the President's fiscal year 2020 budget. The budget advances our Indian Health Service mission to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. The President's fiscal year 2020 budget proposes $5.9 billion for the IHS. This includes $25 million to eliminate hepatitis C and end the HIV epidemic in Indian country. With the resources and tools that we have available today, we have an unprecedented opportunity to make a real difference in reducing hepatitis and HIV transmission. The budget also provides $25 million to begin transitioning to a new and modernized replacement of IHS's electronic health record. Our current aging system exists as more than 400 separate instances that are maintained at individual local facilities across the country. Replacing this antiquated system with a single modern national system would enable IHS to enhance medical quality, maximize the time that our doctors, nurses, and other healthcare professionals are providing direct patient care, and increase the security of our patients' medical records. We've also requested $20 million to launch a national expansion of our paraprofessional program, the Community Health Aid Program. This program of certified health, behavioral health, and dental health aides will enable us to fill critical care gaps throughout Indian country. This program's been used for decades in Alaska to great success, and I believe its expansion into the rest of the country would be extremely beneficial. Our budget proposes an additional $8 million to recruit and retain medical professionals critical to addressing gaps in care. To complement the increase, legislative changes are also proposed to provide tax exemption to our IHS scholarship and loan repayment programs, allowing us to provide $7 million in additional awards and provide discretionary use of all Title 38 personnel authorities, which would provide parity with other federal healthcare providers like the VA. The budget prioritizes direct clinical healthcare services and maintains commitments for staffing of newly constructed healthcare facilities, which required some difficult choices, including a reduction in facilities investments, phasing out or funding the funding for the Community Health Representatives Program, and 2 proposed program discontinuations in our health education program and our tribal management grants program. The budget will enable us to implement our new IHS strategic plan for fiscal years 2019 to 2023, and the strategic plan includes 3 overarching goals, which include access to care, improving the quality of care, and a strengthening of our management and operations. Our plan is the result of robust collaboration with both our tribes and our urban Indian organization partners, and it's our first overarching strategic plan for the agency in almost a decade. The IHS has also realized significant improvements to quality of care, including the establishment of a new Office of Quality at the Indian Health Service headquarters level, implementing a new standardized provider credentialing and privileging system software that's agency-wide and includes the package for all licensed independent practitioners. And we've recently awarded a new adverse events reporting and tracking system that replaces an older legacy system known as Websident. I'm also happy to report that since October of 2018, we've had 16 Indian Health Service facilities undergo surveys. All of those surveys spot on. Everybody's credentialed, everybody's in place. So things are looking great, and with the support of the Office of Quality, we've seen success in the surveys. Regarding the recent media reports on patient abuse by a former Indian Health Service employee, I recently met with tribal leaders in both of the impacted communities to discuss the steps that the IHS has taken to ensure the protection of patients at IHS healthcare facilities. I expressed my personal sincere regret that children were victimized by those entrusted to care for them, and I've made it absolutely clear that IHS will not tolerate sexual assault or abuse in any of our facilities. Our workforce understands how serious this issue is, and I'm proud of the efforts and the commitment of our staff for the progress that we've made, and we will continue to press forward on this issue. The IHS remains firmly committed to improving quality, safety, and access to health care for American Indians and Alaska Natives. We appreciate all of your efforts in helping us to provide the best possible health care services to the people that we serve. And with that, I'm happy to answer any questions that you may have.
Thank you, sir. So from what I understand, and I want to be clear that these actions, when it comes to the Dr. Weber, who was convicted of sexually abusing 2 boys at an IH facility at the Blackfeet Reservation in Montana, sentenced 18 years in prison, and then, found guilty of 2 aggravated counts of sexual abuse of children, 1 count of attempted aggravated abuse of children, abusive sexual contact with a minor. He's right now in the custody of the U.S. Marshals, and he's facing indictments based on what happened at the Pine Ridge Reservation. And I appreciate your due diligence to try to keep this from happening again, your conversations with Indian country. I just want to make sure that when you're looking at your health record systems, that you really have a foolproof function that ensures any complaints against health providers are documented traveling from facility to facility, and that is also going to not just federal facility to federal facility, but that you have figured out how you're going to be interoperable with all state and territory health records, the 2. So I think you covered that well. I thank you for your due diligence on that. Before we go to the other questions from the committee, I just wanted to talk about advance appropriations, because that can kind of set the table for a lot of things that might come up in the conversation as we go over your budget. The GAO has reviewed the use of advance appropriation authority and its application to Indian Health Service. GAO has identified various considerations for Congress to take into account for any proposal change of the availability of appropriations that IHS receives. Specifically, GAO suggested Congress consider whether IHS has the capacity, leadership, and including whether IHS has the process in place to develop and manage advance appropriations. In light of the recent shutdown, it became clear that we need to work towards advanced appropriations, as healthcare law covering other facilities is different because of mandated expenditures. Indian country itself has requested advance appropriations for IHS and Congress, and we're exploring this issue across the aisle. But being aware that the General Accountability Office has suggested that Congress consider the agency's capacity and leadership when deciding this issue, as we begin the discussions this year, and I hope to see fruit next year, because I'm realizing you're going to have to put your house in order to receive these advanced appropriations according to GAO. Can you tell me the process and resources that you think you might need to do in managing advanced appropriations, so we can include them in this bill so that you're prepared if we're able to move legislation in the future?
Thank you, Chair McCollum. We have had robust discussions internally after hearing a great outcry from Indian country about the government shutdown, the 35 days, all of the impacts, heart-wrenching stories from some of our smallest tribes all the way up to some of our very large tribes about the impacts and not being able to service our patients. So we brought that information forward. Tribes have pointed to the VA as an example of a healthcare system that's protected from things like a continuing resolution or a government shutdown. And we've dialogued internally with our stakeholders at HHS, the Office of Personnel Management, with Congressional Appropriations staff as well about this issue. And some of those conversations have led to best practice and information sharing. We did a field trip recently to work with the VA and the Department of Interior to evaluate how they've implemented advanced appropriations, their lessons learned, what they require in terms of resources to provide that. Ms. Church was our representative, one of our representatives there. Do you want to provide some input into what we found in that field visit and what you think our greatest needs will be to implement advanced approaches?
Ms. Church, that'd be great.
Thanks. I'll talk about a couple of different things. One is certainly collaboration with the VA as well as the Department of Interior as we look at specifically how advanced appropriations has been working for the VA, what considerations they have, and specifically on those planning activities. We know they have an actuarial methodology for developing their budget process, which would not necessarily have the same sort of application to the Indian Health Service. But we do have a very robust budget formulation process. We start certainly with the tribal recommendations. In fact, just last month we had our budget formulation process with tribal leaders on the 2021 budget. And the discussion of advanced appropriation certainly came up because that is something that tribal leaders have been recommending for a couple of years. So we are trying to engage with all of our stakeholders and really get prepared in case an opportunity arises, and we are certainly available for any technical assistance.
Well, I thank you for that. Mr. Joyce and I would like our staff to be working with your staff if there's anything we need to include in report language, anything we should be looking at to have included as we move the Interior Environment Appropriations Bill forward, addressing advanced appropriations. And we have to have multiple discussions in multiple committees in order to move the bill forward. And I, as the chief author, and with many on this committee and the other committees that I referenced, we're excited about working with you to get our house in order and then move forward making this happen. So thank you. Mr. Joyce?
Thank you, Madam Chair, and it's one of the rare instances in which I believe in advanced appropriations because I think it's important that you have the wherewithal to continue to do the job, and matter of fact, a co-sponsored bill regarding that. As a husband of a nurse and a co-chair of the House Nursing Caucus, I understand and appreciate the important role nurses play in our healthcare system. In fact, nursing represents the largest category of healthcare providers in the Indian health system and has a major impact on healthcare outcomes. That's why I've been tracking the vacancy rates with considerable interest during my tenure on the subcommittee. Tell me, why did the IHS stop reporting on nursing vacancy rates in FY20 budget justification?
Thank you, Congressman Joyce. And to start, is your wife looking for a position? Because we do have lots of vacancies in the Indian Health Service, and never pass up any recruitment opportunity.
It's wise.
The Indian Health Service has continued to track all of our professional vacancy rates, including nursing, and we break out advanced practice nurses, nurse practitioners, certified nurse midwives, certified registered nurse anesthetists separately, because they tend to have higher vacancy rates than staff RNs or community-based registered nurses like public health nurses. So we do track that information. I think the major change from last year is that we transferred the responsibility away from the Nursing Services Division, who was tracking using a separate in-house system and much focused on manual counts. And we've now enhanced our capital HR, our HRIT system to better do position management, position control, and our human resources has now been tracking that through our HR system. But we do know that our our vacancy rate for nursing hovers at about 27%, even higher for those advanced practice nurses. And we have put forth a lot of effort to strategize on how to address these long-lasting vacancies.
The shortage of primary care physicians, I think nurses are going to be the ones to fill that hole, especially in Indian Health Services. So could you please update us on the trends in nursing vacancy rates in the system over the past few years, and what you're proposing to do to reduce those vacancy rates into FY20?
Yes, sir. Our trend line is relatively stable. We've been between 27 to 30% over the last several years. And so, many of the historical strategies that we've used have not enabled us to impact upon that trend line. So what we're asking through the 2020 budget process is greater flexibility and access to these Title 38 authorities that the VA has. Title 38 would enable us to pay more and to better incentivize staff to come into the Indian Health Service. One of the largest competitors, unfortunately for us, is the VA, and we have many of our nurses who have left our service to go to work for the VA because we just can't compete based on compensation or on leave. So having that parity is important, but it will also help us track those service-minded individuals, people who want to come to work and with a noble mission to get those individuals. We have a number of other strategies that are in tandem with the Title 38 authority, the scholarship and loan repayment flexibilities. The taxability issue is huge for us, but we also appreciate the focus that's been placed on housing, increasing staff quarters through our facilities appropriation budget. In many of our rural communities, we can attract people, but if we can't find them a place to live, we're in a position where they either have to commute in from long distances or live apart from their family for long amounts of time. So having additional quarters in place and having the ability now through the 2019 and 2020 budget to do a housing subsidy for staff, much similar to the way that the commission officers have a basic allowance for housing, to be able to replicate that program for civil service employees in hard-to-fill locations is going to be extremely beneficial. We look forward to implementing that and seeing how that might impact upon our vacancy and turnover rates.
Have you requested time before the authorizing committees regarding the President's legislative proposals for FY20 to get out that information? And if not, why not? But also, do you have the same hiring and salary authorities as other federal agencies in hiring nurses? And if not, can you please highlight how this puts the IHS at a disadvantage?
Thank you, sir. And I will start with the first one. To my knowledge, we have not requested an audience with the authorizers, but definitely happy to do so. Ann, do you want to talk any more about our conversations with authorizers on these proposals?
We've had a few staff-level discussions with the authorizers regarding some of the proposals. For example, some of the HR-related ones, the taxability issue, for example, as well as scholarship and loan repayment on a half-time basis, and our discretionary authority for Title 38. Those are recurring proposals, and so we've had some initial discussions at staff level, and we look forward to some additional conversations coming up at the end of this week and moving forward as we continue to talk about the 2020 budget. So we greatly appreciate the interest and support from this subcommittee and look forward to continuing to partner on this.
It's one of the things we hear a lot if we're helping folks out is that, well, the authorizing committee hasn't authorized this, so we want to be as helpful as we can. And so please update us on the status of the centralized credentialing system, specifically whether it's up and running and whether and how it's having a positive impact on hiring.
Thank you, sir. I'll start there, and then I'll circle back to the hiring salary authorities. The credentialing and privileging software system is fully implemented across the agency. Just last year, if you had asked us the same question, The vast majority of our records were paper-based, manual processed, and now we have over 5,060 or so licensed independent practitioners and some allied health professionals in that system. Everybody's records are digital, portable, accessible from multiple points across the agency. In the past, those paper records were only accessible at the local system. Now we can see them at the area level, we can see them at the headquarters level, and when somebody transfers within the system, we can move the records with the flip of a button. People can see what's included in there. So that enhancement is going to save us a significant amounts of time. It's just hard to quantify at this point, but the amount of time that it takes to run those paper processes has been immense. So the hiring and salary authorities you asked about previously, we do have direct hire authority, and that is something that we have had for some time. But given the somewhat stagnant level of our vacancy rates, I think that it's not necessarily the hiring authority, but more the pay authority, the incentive authorities, and our request to move beyond Title V to Title 38 and potentially even Title 42 to create different pay bands. We have seen.
Would you please, for some of us, these numbers sound fascinating. Behind those numbers is a definition.
Okay. Title V is the authority that we have for most civil service employees. Unfortunately, in many of our clinical positions, it doesn't enable us to reach the salary levels that we need to reach without adding on incentives like recruitment, retention, relocation incentives, which don't count towards retirement pay. So it's an additional financial means to get to the pay level, but it doesn't help people in the long run. Title 38 is the authority given to the Veterans Administration to hire clinical staff, and they have, through that title, higher pay bands and better recruitment incentives, mainly targeted at clinical positions. So we'd like to obtain that ability to use that clinically oriented title for our professions as well. And I believe that's the biggie. Just one example, the VA has the authorization, the ability to provide individuals with 8 hours of leave accrual on day one, where we start everybody at 4 hours unless they've got previous experience working in a healthcare system. Then we can do a lot of paperwork to justify to get them either 6 hours or 8 hours. So it's administratively burdened for us to get to where the VA can just move with having that authority in place.
Thank you. Are you back?
I have no idea how much of that is statute, how much of that is rule. If there's things that are, if it's rulemaking, we can have conversations about how to help maybe speed that up. If it's statute, I think Mr. Joyce is just itching to talk to the authorizers, it sounds like. Mr. Kilmer.
Thanks, Madam Chair, and thanks for being with us. Over the past years, there's been a growing effort to shine a light on the once silent epidemic of missing and murdered Indigenous women and girls. A lot of that effort has been led by Seattle's Urban Indian Health Institute, which self-funded the first comprehensive report on missing and murdered Indigenous women and girls. I brought a copy of the report for you, and I would like to have permission from the chair and the ranking member to submit one for the record as well, if that's all right. This one's.
Without objection, Mr. Joyce? So ordered.
Thank you. It's a really upsetting report. It was devastating to learn from this report that Washington State had the second highest number of cases nationwide, and that Seattle and Tacoma, which is in my district, were among the top 5 cities impacted. Having said that, I'm just very grateful that the folks at the Urban Indian Health Institute and others are working to ensure that we don't stay the course on this, that we don't let this be something that doesn't get the attention that it needs. Having said that, the lack of data and resources have made it very difficult to fully document this crisis, let alone to begin to resolve it. This report, which provides the most comprehensive accounting of this crisis to date, is merely a snapshot of the epidemic. Last month, we had tribal leaders and representatives from all around the country testify about the need for dedicated funding to address this issue. Clearly, this is a multi-jurisdictional issue. The DOJ has a role to play. Other law enforcement programs have a role to play, but this report demonstrates that the Indian health programs also have a valuable role to play as well. And I didn't see anything in your budget request that recognizes the role that IHS can play and should play to support efforts not just to document this issue, but actually begin to combat this crisis. So I'd like to ask what resources you think the IHS can and should bring to bear on this issue to really begin addressing what I think is a significant threat to the health and welfare of Native Americans.
Thank you, Congressman Kilmer. And definitely within Indian country, this is an issue that we have heard a lot about and we've talked a lot about internally. I think one of the programs that I would point to that's been supportive of these conversations is our sexual assault nurse examiner, sexual assault response teams. We have dedicated resources over the past several years to these efforts in creating at the local level care teams who can address sexual assault and then get those individuals and the related evidence to justice and law enforcement so that these can be followed up upon. I've had Amnesty International individuals, probably tens of thousands of emails that I've received personally from individuals requesting that the IHS ensure that we have SANE and SART programming in all of our hospitals and clinics. We do have national level sexual assault policies on the books. What can we do beyond that? I think the close collaboration and discussions with Department of Justice, Bureau of Indian Affairs, to alleviate any jurisdictional issues or concerns about follow-up on cases. You mentioned better IT systems and tracking. That is a major focus of the work that we have underway with our EHR modernization, is the ability for our system to talk to others and to utilize that data for not only clinical decision-making, but also to help with issues like this and to be able to compare and share information across systems with justice and community health advocates as well.
Okay. Thank you, Madam Chair. I'll have other questions I'll submit for the record, but thank you, Madam Chair. I yield back.
Well, thank you for bringing that up, Mr. Kilmer. And I know the First Nations in Canada have been doing a lot of work on this, and I hope if there's lessons learned from how they're treating these victims of sexual abuse as well too. And as Mr. Kilmer pointed out, some of this is not necessarily in our jurisdiction for funding. But we will be having conversations with our colleagues. And it wasn't that long ago, Mr. Kilmer, that we didn't even have sexual assault kits available. Mr. Simpson and I were going around to reservations, and that was a frequently asked question: do you even have kits available? And is anybody trained to use them? So there's been progress, but there's more to do. Mr. Joyce, or I can go to Ms. Coleman.
Sure.
So.
Thank you, Madam Chair. Good morning to you. Thank you for being here. I just wanted to highlight the fact that Mr. Kilmer was specifically asking about the issue of missing Indian women, and what is it that we can do about that, or what are we doing about that? Not just those that we know that have been sexually assaulted, but the fact that there's this huge number of missing women that we don't know much about. Despite a lot of the critical work that the Indian Health Service does, the health disparities facing American Indians and Alaska Natives remain stubbornly high. Specifically, the high rates of maternal and infant mortality among American Indians are very alarming. According to recent data, American Indian and Alaska Native infants have a roughly 55% higher mortality rate, while another study showed the maternal mortality rate was 4.5 times higher than for white mothers. In a country as rich as ours, that's really completely unacceptable. And the Indian population is not the only minority population that faces this disparity. And I've dealt with that in other areas. So first, I would like to know, what is the Indian Health Service doing to address this problem?
Thank you, Congresswoman. Definitely, maternal child health is a major priority for our agency. We have had historical relationships, some going back 40 years, with the American College of Obstetricians and Gynecologists and the American Academy of Pediatrics. There is a Council on Native American Child Health that's been in place for some time. We work with both of these groups on an annual basis. They provide us consultation. They come in and share with us the best practices in maternal child health. They go out and they review our facilities. As a healthcare system, mainly based on primary care, we only birth probably 10% of American Indian children. In our facilities, 90% of American Indian children are born in facilities outside the Indian Health Service. But for those that we do, that prenatal care is vitally important. Recently, we've had a significant emphasis on opioids and neonatal opioid withdrawal syndrome. We've developed, in collaboration with these entities, treatment protocols and standards. And if we want to go any deeper, I do have our Chief Medical Officer here who would be happy to.
I think that you kind of hit the nail on the head when you said the majority of the births take place in other hospitals. And those are the hospitals I think we're experiencing the greatest question. Why is this happening? Even if you apply equality in socioeconomic status, there's still this disparity in the death of minority mothers and infants. And so that's an issue that I think needs to be really tackled. I'd like to go on to another area. I was pleased to see that your budget proposal includes an increase in efforts to combat HIV and AIDS in the Native communities, which, as you know, have had increasing rates of diagnosis in recent years. Could you elaborate on what your plan is for reducing new HIV diagnoses and how you plan to collaborate with other agencies on this effort? And also, what plan do you have for increasing access to pre-exposure prophylactics or PrEP among at-risk populations?
Thank you for those questions. And the Indian Health Service is definitely very excited about the new proposal that's come out in our 2020 budget and the announcement that the President made at the State of the Union address in February. The Ending the HIV Epidemic, a Plan for America, includes as a goal reducing new HIV transmissions by 75% within the first 5 years and by 90% within 10 years. The major goals, just in general, it's identify and diagnose those individuals who are out there who don't know their current status, get those people into treatment and keep them in treatment, and then protect those individuals who are at risk for contracting HIV through the use of PrEP. We know PrEP's expensive. We recently ensured that PrEP was included on our Indian Health Service core formulary, so it's available to all of our sites. And we are working with the Centers for Disease Control and the Health Resources and Services Administration and the National Institutes of Health so that we're working collaboratively to address issues like data. We're focusing in this particular initiative on 48 counties. Those 48 counties, Washington, D.C. and San Juan, Puerto Rico, combined represent 50% of those new infection rates. And this is 2016 data. And we were also focusing on 7 rural states that have an overpreponderance of HIV infection. Some of those right in the middle of Indian country, Oklahoma, Mississippi, where we have a number of tribes located, and we'll be focusing our resources in those specific areas.
Thank you very much. I yield back.
Mr. Joyce.
Thank you, and I applaud the efforts to do on the sexual rape kit, the backlogs, as I was co-chair of another Subcommittee, unfortunately, about preventing sexual assaults. We had a hearing on it and brought in Mariska Hargitay, who has helped draw a lot of attention to this. But in Cuyahoga County, which is Cleveland area from where I'm from, in just going through and gathering that information and then applying against the database, which has obviously been expanded, it's amazing how many serial rapists got taken off the streets in a short period of time. So if there's ways we can help you, encourage you to find funding from other sources as well on that, we're glad to help. Well, unfortunately, Indian country also has a problem that swept this nation with opioids. And so I was wondering if you take a minute to explain whether there's sufficient funds in this budget request to address the opioid epidemic.
Thank you, sir. The Indian Health Service received $10 million last year specifically for opioids, and we've been doing a lot of consultation with tribes and hearing a lot of feedback throughout the country about the needs. And definitely opioids are a huge need in many of our communities. We've seen examples and personal family stories about individuals who've been impacted. So there's no doubt that there's a great need out there. Tribes also have access to the Substance Abuse and Mental Health Services Administration funding. There's $50 million that has been set aside specifically for tribal opioid response grants. What the Indian Health Service has done is really focused on the neonatal abstinence syndrome. So we've developed protocols. We've developed several policies. We have a heroin, opioids, and pain efforts committee that has the opioids efforts under their purview. They're leading the way for our agency, and they've been doing so for several years, even before the opioid crisis was well known to most Americans. But the work that we'll continue to do will be through greater flexibility in the use of our mental health and substance abuse funding. We've asked for increases in both lines, and what I'm hearing a lot from our tribal leaders is that methamphetamine in places like Montana continues to be a huge concern. Alcohol still prevalent and very much a problem through much of Indian country. So it's vitally important that as the country's focusing on opioids, that we provide flexibility to our tribes and other stakeholders to be able to use funds to address these other issues as well. So that's really a big focus. Additional funding to address any mental health substance abuse issue is where we're at.
Outside the IHS budget, are there federal funds available to you to help combat this problem? And to give you an idea, let's talk about the sexual assault kits. Local attorney general in Ohio contributed money. The local prosecutor took money. They have a little more flexibility in moving their funding, but from another program and pushed it into this. And like I say, the results were outstanding. So obviously when you're in the midst of something like this, it's important to try to cobble together all your resources.
Yeah, so I did mention the SAMHSA Tribal Opioid Response Grants. SAMHSA also has funding for state opioid response grants. A lot of the states have been working with their tribes, some states better than others, about giving them access to those funds that are coming down from SAMHSA and the CDC. Each of the operating divisions have a little bit different focus. So some of the strategies that are being used are to provide better data. So CDC and the National Institutes of Health are focused on data and research. And our tribal epicenters may have access to some of these research grants and data grants. SAMHSA for healthcare and better data surveillance. So really they're the major players other than the Indian Health Service for the direct healthcare service provision. Some other activities that we've undertaken is making sure that we have narcotic opioid reversing medications on our formulary, things like naloxone and Narcan. We want to make sure that those are readily available to law enforcement and other first responders so that people aren't searching for those out in rural reservation areas, that they're readily accessible through our Indian Health Service and tribal clinics.
Well, thanks. That answer addressed some of the other questions I had.
Oh, Great, thank you.
I yield back.
Thank you. Mr. Joyce, I'm going to kind of combine some questions together, and what I would like us to do, if there's something you want to add to that, just, let me know, and we'll work on this together, because it's going to help you and I determine how we put our budget together for this subcommittee.
Well, once again, it's just you and me, so I guess
Yep.
we can collaborate.
So what I'm saying is, feel free to interrupt me. You're a dear friend, and you can do that, because you'll be adding value to the conversation. So the mission of the Indian Health Service is to raise the physical, mental, social, spiritual needs of the Native Americans and Alaska Natives to the highest level. February 2019, weeks before the president released his budget, your plan that you put forward identified 3 strategic goals, which I agree with: to ensure that comprehensive cultural appropriate personnel and public health services are available and accessible to Native American and Native Alaskan people. 2, to promote excellence and quality through innovation in Indian health systems to optimally perform, in the organization. And then 3, to strengthen HIS program management operations. So could you, and I mentioned this in my opening statement, I thought there was conflict to this wonderful proposal that you've put together with and then add the president's budget in here, kind of takes it a step backwards. So could you maybe explain to me, pull this apart, how the proposed increases in the 2020 budget, which doesn't even increase cost and pay, which we were talking to with Mr. Joyce about nursing and other things, contract support costs, and inflation, let alone the housing that you were talking about. How is this going to work to help you fulfill its mission? How does this budget work with this wonderful mission statement you put together?
Thank you, Chair McCollum. And thank you for recognizing the hard work that went into the development of that strategic plan. It was more than an 18-month process, robust consultation with tribes and conferral with our urban programs. So it was a labor of love. And as I mentioned, we've not had a guiding document in the agency for a decade. Budget alignment was a key priority as we developed this year's budget, as well as performance management. We're also aligning our senior executive service performance contracts and our civil servant PMAPs, or performance management appraisal program, with the strategic plan. We've requested funding, $2 million in this year for further supplement of our Office of Quality. Our Office of Quality will be providing the headquarters oversight, and I want to make sure that everybody knows that quality is not new to the agency. We've had quality programming, compliance programming within the Indian Health Service since its inception. However, the majority of those quality resources have been at the local level, at the hospitals and at the clinics, some limited oversight at the area offices. What we've really done is focused on headquarters level oversight, sharing of best practices across the system of care, and more fully supporting governance structures, development of governance structures. One example is the recent development of a quality assurance risk management work group or committee that will be institutionalized at the national level. So they'll be taking early warning systems or red flags that are coming up from the various reviews and circulating those through forums that are also recently developed. In terms of budget requests and alignment with how we're improving access to care, I think that our requests on staffing, we've made commitments in joint venture programming, and we have associated staffing packages that we want to make sure. One example is our increase in public health nursing funding. We've asked for additional PHN funds because we have 3 joint venture projects that are starting up in 2020. One large program at Cherokee. We have a program at Yakutat up in Alaska, and another Isleta del Sur in Texas. There will be additional PHN FTEs associated with those joint venture projects that will expand access to care with these new facilities, improving the quality of care. On top of the Office of Quality stand-up, we're also forging strong relationships. CMS has funded a partnership to advance tribal health, and we've been upping the game in terms of training of our staff on continuous quality improvement, and with the improving management and operations, we want our quality improvement professionals and all of the training and advancement that they've received to be used not just to improve our clinical operations, but also our administrative and our financial operations as well. We're investing in business intelligence technology. We've used CLIck technology to help us make informed decisions, and we started that on the clinical side, but have really used it on the administrative and financial side to our benefit as well. So I hope I kind of touched on all three areas. But
That touches on it, but so would you explain for the record what community health representatives do? And then for the record, the Indian health professionals that you're bringing on, what are the different outcomes of these programs? And because I'm trying to, I think it's a worthy goal, this CHAP program that you're putting forward. But what we heard in public testimony from the tribes is they want to have more contact with community health representatives, not less. And I know you were faced in a dilemma trying to figure out how to work under the budget that the president gave you, but something's going to be lost when something's gained here, the nearest I can tell.
Thank you, Chair McCollum. Definitely in my conversations with tribal leaders and even internally with the few community health representative programs that we run, there's no doubt in my mind that this community health representative services are of great value. The dilemma that we're running into is in being able to justify the efficient, effective, and accountable use of those funds. Our data identifies that we've had a reduction of more than 1 million encounters for our CHRs, and likewise on our health education side, we've seen a reduction of more than 270 encounters. Now that may be a data issue, that may be tribal programs who have moved on to NextGen or Cerner or Epic, different IT systems, and issues with reporting. But there's also choice. Tribes have the choice once they contract their programs, of which 97% of our community health representatives programming has been contracted. They have the choice of whether or not to provide that data back to the agency and for us to be able to aggregate it and report back nationally. So with some of those choices and with some of those data issues, we're now in a position where we're having difficulty justifying that those resources have been used effectively. Now, anecdotally, in my conversations with staff members and directly with CHRs, I know that they're not just providing transportation services, which is a big misnomer. They are sometimes the only people that some of our bedridden patients see for weeks at a time. They're following up on surgeries. They're delivering medications. There are a lot of efforts that our CHRs put forth, getting into the community, speaking the language of our people, that it's difficult to replace. Now, what our thoughts are is how can we up the game and how can we help to ensure that we can continue to justify funding going into our paraprofessional ranks like CHRs, like the CHAP program, and the dental health aid program and the behavioral health aid program. That program comes with a required level of education and certification. So there'll be an assurance that individuals are trained at a certain level. I've visited some of the sites in Alaska and recently in the lower 48. There are several states, I think we're up to about 10 or 11 now, that have approved the use of dental health aids, and many more who are looking at how to reimburse and sustain community health worker services. I was just in Michigan this past week, and there are evaluative studies that the tribes are undertaking themselves. Grand Traverse is a good example. They had a PhD student do his study on the comparison of CHR versus CHAP program, and early indication is that they would be better served as a community to invest in the CHAP program and to work with the state to have those services reimbursed as they establish relative value units and work with their state Medicaid program. So we kind of see the transition from CHR to CHAP as an elevation, and many of our CHRs are perfectly suited and can become certified as CHWs and can advance. We've seen examples in Alaska where their community health aides have advanced all the way and decided to become physician assistants. So there's a lot of growth potential in these professions as well.
Well, that's quite a leap, though, from someone doing spot checking on medication to a PA, but I can see where that could happen in some instances. I think we'd like to work with you a little more to understand what's going on, because I see them as having two separate functions. Sometimes one person can do both functions. Sometimes one tribe might need, depending upon their location and the needs of the tribe. So I think your goals here are noble. I just want to make sure that before we start shifting resources that are so very limited that you have, that we don't have an unintended consequence with all of a sudden a tribal nation saying, well, you know, I kind of like the way you're going with the CHAPS program, but I didn't know I was going to lose this, because it all comes down to dollars. And I appreciate your honesty in saying you don't know if the data points that you have really reflect what is going on in the community, and maybe that's something we can work on together for you. But you rely upon them to do some reporting. They don't do the reporting. You don't have the information, therefore it shows up as a negative. So I think there's some dialogues that need to take place. Mr. Joyce, I wanted to kind of talk about the GAO high-risk study and accreditation, because I think they kind of go hand in hand. The Government Accounting Office added the Indian Health Service and the Bureau of Indian Education to its high risk for ineffective administrating programs. Last month, GAO indicated that IHS had partly met all 5 criteria: leadership, capacity, action planning, monitoring, management of healthcare programs. However, IHS continues to remain on the high risk. GAO has identified several priority actions for the service. You're well aware of them: permanent leadership, corrective action that finds root causes and identifies solutions, provides for sustainability, for completing corrective measures, ensuring agency-wide standards for the quality of care developed, facility performance. It goes on and on. You know what they are. So we have had a very serious issue, as you know, with accreditation. And the subcommittees continued monitoring the challenge of several hospitals in the Great Plains area to maintain their Centers for Medicare and Medicaid Services at CMS certification. For fiscal years 2018 and 2019, Congress provided $58 million for each year to address these challenges. Could you please discuss these current challenges at each of these hospitals? Can you provide us a bit of an update? Because many of the things that are highlighted in the GAO risk assessment were some of the exact same failures that led to the loss of accreditation. Mr. Joyce, anything you want to add to that?
Well, I appreciate that. Following up on that, we can say the answer.
Okay.
Thank you, Chair McCollum. Appreciate the highlight of the GAO high-risk list. That was one of the items that I walked into back in 2017, coming into this position as being placed onto that GAO high-risk list status as an Indian program. And we have made significant progress. We started with 14 open recommendations from the GAO. We're now down to 7, so we've halved that number. And in just the last 2 months, we've requested closure of an additional 4 open recommendations, and those were tied to our purchased and referred care program. We've recently published an update to our policy chapter, and 3 to 4 of those open recommendations were tied to that update. So we expect to receive news from the GAO at any time that we are down to 3 open recommendations. 2 of those, the improvements have been made, and they just want to monitor us to ensure that they're sustained. And then 1 is a new recommendation related to provider recruitment, which we're thankful for and look forward to working on. So a lot of progress on the GAO high-risk list. With regards to accreditation and quality improvement issues, root causes, again, recruitment and retention of qualified staff in these locations, having leadership, CEOs, and then quality managers, which we've talked a lot about today, but also having clinical directors, chief nurses at that table as well. I think that one lesson learned is that our agency needs to continue to invest in our workforce, grow our own. We can't expect somebody to come in from the outside or to be able to pull executives from other health systems. We are a small system, but we have very unique needs, and oftentimes the best people to do that are those who grew up in our system. So investing in our workforce is key. We've implemented an executive leadership development program, and I've mentioned the partnerships we have in place with CMS on quality improvement training. Other root causes of our accreditation and certification woes include keeping our facilities up to date. That is a significant problem for us. The average age of our facilities is 40 years old. In the healthcare industry, the average age of a hospital or a clinic is 11 years. So we're 4 times the age. That additional age comes with a lot more cost in trying to upkeep and maintain and meet certification standards, which are ever increasing, the bar or the threshold. So we appreciate all of the funding that's been provided to help us address that, specifically with the accreditation emergency funding, that $58 million. We have used a good portion of that to meet emergency department staffing in the Pine Ridge and Rosebud hospitals. And we have addressed several longstanding renovation projects, emergency department renovations, heating and air conditioning upgrades. I'd like to ask if Admiral Hartz can provide any additional input on our facilities-related issues that impact upon our certification and accreditation.
Thank you, sir. Admiral Yaki has pretty well summarized an awful lot of it, but as he pointed out, when we have facilities the age that ours are, you're just going to run into issues because of the changes in the demographics of delivering health care. It's totally changed, right down to the equipment we utilize, and all the technology that's in your phone is what's in biomedical equipment today. And that's really critical. So not only do we deal with this from a facility standpoint, but what that facility is to those that we're trying to recruit and retain. You know, if they're coming out of that fine institution in North Dakota where I came from, or coming from Harvard or Stanford or from the Cleveland Clinic area or from the University of Minnesota, they're trained on the technology that is expected for good diagnostics. And that is something that makes a difference when you come into these facilities. And that's what the Joint Commission and the other folks are looking for, is that you've got the capability to deliver high-level quality care regardless of what that facility is. And that's where we're trying to make these inroads. And we are, thanks to the appropriations that you folks have provided in prior years recently. Thank you.
Mr. Joyce, on this, because I was going to ask how the $2 million, how that would be used.
Well, I do have a follow-up on that. Thank you. Preceding you, Admiral, in 2016, the Facility Needs Assessment Report to Congress, the IHS stated if appropriation trends continue, any facility built in 2016 would not be replaced for 400 years. This subcommittee responded with significant increases over the past 2 fiscal years to start to reverse this trend. This FY2020 budget now proposes a $77 million cut to health facilities construction. Are we to interpret this as a cut, as a signal that Congress solved the problem with the FY18 and 19 appropriations? Or if not, then why the cut?
Thank you, Mr. Joyce, and appreciate definitely all the funding that was provided to the Indian Health Service and all of our facilities lines. We still have a significant backlog of healthcare facilities that need to be constructed. I think quantification-wise, we're looking at $2 billion of projects still remaining on our grandfathered list of both inpatient and outpatient facilities. And we have a backlog of essential maintenance, alteration, and repair that is sizable. I'm going to ask again if I could turn to Admiral Hartz and have him provide some greater insight into our needs in those areas.
Thank you, sir, and thank you, Congressman, for the question. The increase that the Congress provided in FY18 and 19 for healthcare facilities was pretty spectacular, and it did make a tremendous dent in that 400 years. We probably still won't see that, you and I, but getting that taken care of. But it was remarkable what that did if that was sustained. And we recognize that there's, in the request this year, that it is less than the $240 million that you folks appropriated. But at the same time, you know, we thank you and the HHS again for what it has done, what you have done in support of the non-expensed funds that have become available from the appropriations actually from other committees. And we've been able to put that in toward addressing federally owned facilities. And that amount has been very, very significant. And we're expecting that we will be able to continue that and sustain the tremendous efforts we've done the last couple of years. I might also add that with that FY19 appropriation, Admiral Yaki indicated that we still have a $2 billion need for all of them on that project list. However, this past year, we were able to put resources into every one of those remaining projects on that list, you know, either for continuing phase funding on a project or to actually get into some very detailed planning efforts on the very two large projects that are on that list. So we're making the inroads that the Indian people want for us to not only improve access, but improve access to quality health care. Thank you for the question.
Thank you, Madam Chair.
Well, I've got another question for you, Mr. Hartz. It's on sanitation facilities construction, and I'm going to set the scene here for you. Mr. Joyce and I represent the Great Lakes. I'm from the state of 10,000 lakes, and sometimes there's a misnomer that you can just dip a cup into any lake, any stream, any river in Minnesota and drink from it. That's not the case. The water quality on the Fond du Lac Reservation is very poor and generally cannot be used unless it's treated. Where the source water is really poor quality, treatment may leave it unacceptable level of byproducts that also fails to meet water quality standards. Currently, the tribe is providing point-of-use filters to over 50 homes and a community center. The tribe needs to drill several new wells to access better quality water source, but the water will still need to be treated. The tribe will also need to build a new water treatment facility along with a water tower and new pipelines to establish redundancy in the system to protect users and to aid in fire protection. And the tribe estimates that cost at $2.5 million. In fiscal year 2019, Congress appropriated $192 million for sanitation facilities construction. Well, I understand that IHS has a priority system for sanitation facilities construction. I would like to know how these funds are going to be distributed among regions for sanitary construction projects. So I'd like you to explain to me the formula. It's $107 million, and it's available to serve 37 tribes. This is very, very troubling. The IHS sanitation construction need is approximately $2.64 billion, yet the service only requested $193 million. At this rate, the expected time, what's the expected time frame? Because in Indian country, I mean, there's backlog projects all over Indian country, and the same reservation can be facing multiple backlogs: a school, housing, roads, hospital, water, sanitation. So how does this reduction going to impact your ability to work down the priority list that's in the budget that has been proposed?
Thank you for the question, and I'm very well aware of your 10,000 lakes because I'm from North Dakota originally, and I've been over there
I'm
many
sure you're
times.
jealous of all of them.
We are, no doubt
My
about
mother's
it.
from North Dakota.
The 192 million that was appropriated in FY 18 and FY 19 for sanitation facilities was a boost of $100 million. So once again, my thanks for what you folks did in healthcare goes also to sanitation facilities. That amount we're asking for the same amount in 2020, the 192 million. The universe of need out there is $2.7 billion. Within that, we've identified among the areas and tribes have all submitted their kind of rated and ranked by a system, giving highest priority to those homes that do not have water and sewer or do not have water or sewer. And this particular project that you're talking about, I am familiar with it, has come up because it does not meet the maximum, it violates the maximum contaminant levels there in Fond du Lac. And the project is a doable project. It did not reach the threshold in 19 among the highly ranked projects within the Bemidji area. How do we distribute the resources? It's based on the need that's identified all across Indian country, and but with a partnership that we often do with EPA, we anticipate that this project would be given based on the federal review and the tribal rankings. The tribes get an opportunity actually to put points in for the specific projects that we remain optimistic at this point that it might be able to be reached in 2020.
Well, that would be nice, because right now the tribe, my understanding, and you can correct me if I'm wrong, if you're reimbursing them, is providing the point of use filters for over 50 homes in the community center.
Yeah, typically, we don't reimburse for
Right,
projects.
but if they didn't provide the water, that would move them. If they didn't provide the filters for the water, that would move them up higher on the list. But they're doing the right thing.
Well, no, they're doing the right thing, but still, the overall community water supply is one that's under violations from EPA. So that is really critical, and that needs to be abated as quickly as we can address, the priority projects that are identified. And so thank you for bringing it to our attention, and we're hopefully when the agency returns next year, we'll have some good news.
Great. To the panel, we're going to submit some questions for the record on electronic health record systems, the self-governance leases, in regards to the federal court that ruled that the Indian Health Service has to fully fund the cost of Section 501 self-governance leases. So we'll ask you to respond back to that. And then I'd like a better breakdown of how you're going to use this $2 million for the Office of Quality, because you've identified a lot of areas that you're working. You have a plan you're moving forward on. So if you could show us how that's going to fit into the Government Accountability Office recommendations, or how if some of that funding can be used to better track what we were talking about earlier with community health resources, so that we make sure when you're shifting some of these resources over to CHAP and that we're doing it in an efficient way. And Mr. Joyce and others who are not with us might have a few others for the record. But Mr. Joyce, I understand you don't have any further questions at this time except for the ones we're going to put to the record?
That's correct, Madam Chair.
Well, I want to thank all of you for all the work that you do. You got folks sitting behind you that work really hard. We thank you for all of your work. We know in Indian country, the backlogs are alarming. They're disappointing. They're heartbreaking. But they're a day-to-day life that many of our Native American brothers and sisters are facing. And we want to work with you and work with tribes to get rid of the backlogs, to get rid of the log jams as we have in Minnesota, but also to make sure that we're putting forward quality health care. So I know that that's your goal every day, and that's our goal, to work with you to provide that in a more timely, effective, and efficient manner. And with that, this committee is adjourned.